Good afternoon, friends, respected chairpersons, madam, sir. I find some of my RCGP colleagues over here, like Kane, Dr. Manning. I'm missing Annette. Probably she will join late. I am Professor Ray. I am here to speak on some of our experiences, what we have gathered between 2013 and 2014, when we started a challenging course on family medicine, fellowship course, launched by the government of West Bengal. The concept of family medicine, as you know, in India, it has started long back, but educationally, it has not taken off. And as you know, anything and everything for education purpose, the regulatory agency, Medical Council of India, has to give nod. And Medical Council of India has given the nod to run the master's course. A few institutes are running from South India. And planning to that and contemplating to that, Government of West Bengal started thinking on initiating such courses in their state. As you know, in any match, there are quarter-final, semi-final and final. So with the fellowship course, we have started the quarter-final. From this onwards, we are going to upgrade this course in the name of diploma for 2 years. So we'll go for semi-final, and if everything goes well, we'll go for master's course final in the long run. So our partner from Royal College of General Practitioners immensely helping us by framing the curriculum, coming as a faculty members time to time, coming as an evaluator. So it's a sandwiched, bridged effort by Government of West Bengal and Royal College. I do not know, is there any other state government in the country has taken this challenge? Yes, Chayan has come and it has come. Thank you. Thank you. If there is any question, they will be able to answer, if I cannot. So I'm now little protected by them. Yeah. Basically, my background is I'm a clinical pharmacologist, now doing medical administration for last 15 years. So when government asked me or directed me to start this course, I took the challenge. And let's see how it came, what are the strengths and weaknesses on that. Of course, the contributors, in one side, Government of West Bengal, myself, my Director of Medical Education, Professor S.K. Bandopadhyay, and Professor Biswas. On my right hand side, the persons, some of them, Chayan is sitting, Annette is sitting, and other persons are also with us. Of course, Petra's name has been missed, so Petra also should be kept into consideration. So we started this chapter first in 2013, when the course was conceived by Government of West Bengal, and as a regulatory agency, state medical council West Bengal has given the nod, and University Health Science West Bengal has given the affiliation. So with all these blessings, and the course was accredited, of course, by RCGP. So with these 4-5 supports, we started this course, 1 year fellowship course in family medicine. And 2015 onwards, we'll be going ahead with the diploma course for 2 years. Already the students have got admitted in the course, and we'll start or launch the course from January 2016. This is a working group, 4-5 people, and this is the office. In front of our office, we are standing. And of course, there is another person, another organization, that is British Deputy High Commission. They have also come forward to help us. So all necessary supports, logistics, etc. And with these few assets, we have started the training pilot on this diploma course in family medicine. So you know, RCGP in UK, they have the roles are professional membership body and guardian of professional standards for general practitioners in the UK. They are the key voices in primary care in UK and internationally, working to improve GP education and training in UK and internationally, and they are the international leader in primary care development. When RCGP has expanded their roles in India, they are committed to support the development of primary health care in India, which is a partner country in college's 10 years international strategy. The current activities of RCGP in India includes for family medicine training development support in West Bengal, Bihar and Apollo, and Annette is a person to steer these activities. MRCGP International South Asia, participation in UK India Joint Working Group on Health, numerous additional formal and informal links. My institute, Institute of Health and Family Welfare, which is an autonomous institute run by Government of West Bengal, they have the roles here in promotion of health and family welfare programs, education at state and national levels. We are running many courses, barring this family medicine course like hospital management, health management, etc., etc. Capacity building in health sector. So all professional persons are being sent for training to generate resources. We conduct operational researches, maybe epidemiology. Evaluation of training programs. There are a lot many training programs in government sectors, and we are the persons to evaluate and upgrade, framing, constituting everything. Then advocacy for the government. Government sends their requisitions to us, and we frame the research programs, and accordingly government funds us, and we do it. Specialized healthcare services. So these are the few activities we have. Now coming to the business proper about the primary healthcare. As you know, the primary healthcare provides a range of essential preventive, promotive and curative interventions to the underserved populations. This is very important at both urban and rural settings. By and large, we know the underserved populations, they stay in rural, not that. There are many underserved populations, they are in urban areas also. So all are encompassed under that. So this is a picture of the primary health center. These are the posters we keep. Of course, they are all in Bengali language. These are all health education, promoting health education in that way. There are other services like maternal, neonatal, child health, immunization, family planning. We have infectious and non-communicable diseases. Services are provided under national health programs. So people are these are the workforces, right from doctors to health workers, nursing staff, pharmacists, counselors, so on and so forth. We provide essential medicines to our patients. You know, essential medicines are the lists of medicines, group of medicines, which are required to treat majority of the local ailments. And there is a list, and the list is being updated, list is being prepared by the experts depending on the determinations and distributions of the diseases and the local ailments who report to the hospital. At this point of time, Government of India have 348 essential medicines, but in our state of West Bengal for primary care, we have cutled down to 50 medicines. And the point is that all essential medicines has to be available, has to be made available at all times of the seasons in appropriate dosage formulations. That is the criteria one should follow. There are two pictures over here. You see, on one side, a lot of gathering in front of one building. This is a gynae obstetrics building of RG Medical College. It's a tertiary care hospital. You see all patients and patient parties are waiting outside the hospital because of the less number of beds, hospital beds. So it's an overcrowding, as you call. And on the other side, there's a primary health center. There are also this crowding. The question is why the overcrowding in hospital happens. There are many researches on that, but we could find out there are two reasons. One is unnecessary referrals from the primary and secondary to tertiary centers, and at the same time, the bed turnover situation, if it goes long, prolonged, if it is not quick, then probably there is a stagnation which causes that. So our government wanted to increase the activities or improvise the activities at the primary level and secondary level, and for which probably the family physicians, family medicine physicians will be having a challenging role to do that. One side you see how the pregnant mothers are waiting for their deliveries, on the other side you see how we could accommodate. So we want this situation to be converted to the right situation. So for that matter, the first thing we need to lessen the overcrowding of patients in tertiary cares. There are many issues and challenges in family medicine in India, like wider ambit of work and responsibilities in rural and semi-urban areas. Recognition of the discipline is very important. Say, few minutes back, one of my colleagues was asking me, why students are not being attracted to the family medicine in your course? Yes, only because that the discipline has not taken off. There is no official sanction of the discipline. The discipline has not become popularized, neither in the government sector nor in the private sector. So once you do it, you won't get any taker of the course. So this is very important from the beginning. As you know, our health minister, Madam Health Minister, is also chief minister. So we had several meetings with her, and we had to explain her that the discipline has to be made first accepted to the population. Then cultural perceptions of primary health care and family medicine. Now there are long debates going on in the morning session that primary health care and family medicine, how they are interlinked. So that grey areas has to be solved. Then regulatory framework for family medicine at infancy, like our regulatory agencies like Medical Council of India, like West Bengal Medical Council, the other state medical council has to come forward and give the affiliations and approvals to these courses. Low insurance coverage at primary health center and family medicine. Patients' expectations. As you know, this is a country which is not a UK, which is not a Canada. See, they have the literacy rate, socio-cultural beliefs, etc., differs much from the Western countries. So one has to keep into consideration those factors. Career progressions and incentives. Why a doctor after doing his bachelor degree will come to family medicine? What is the prospect of it? Is he going to become a professor like us at the end of his career, maybe at the middle of his career? So once the discipline is being recognized, then the human resource also has to be made, the career incentive has to be there. So what we have perceived, the first our job is to declare the discipline an official one for the government. Second, to create positions for the specialists who will qualify these posts and give them necessary requisite incentives so that they get attracted to come. The roadmap of this program, fellowship program. So first meeting held in Delhi in 2011 with the ministry, where our health secretaries were present, and our health secretaries those days, they took the challenge that we'll start it from West Bengal. Then meeting held in Calcutta between RCGP persons and our government officials. Decisions to follow the Maharashtra model of National Health Mission. There's a model called Maharashtra model, I'm not going to explain that. 4 core training areas we identified, because in West Bengal we have seen there are 4 core areas where the human resources are absolutely necessary. Like pediatrics, neonatology is 1, anesthesiology and critical care is a 2nd, gynae obstetrics is a 3rd, and traumatology and orthopedics are the 4th. So if we can generate the 4 category of specialists in these sectors, probably our purpose will be served at this point of time. 3 teaching hospitals and faculties were identified. Visit of our Director of Medical Education in UK in 2012, where the MOU was signed, probably Dr. Manning is sitting, he signed from RCGP side, and my director S.K. Bandopadhyay signed from government side. Then regulatory clearances obtained from necessary agencies. An academic program was launched in 2013. So the training pilot, how we started. First we recruited the medical graduates from both sectors. That means open, the fresh medical graduates, and the government doctors who are already in the services. We call them sponsored candidates. For family medicine training was challenging. The 1-year pilot fellowship program, 2013 and 14, aimed to improve the training and quality of doctors recruited for family medicine roles in government primary health centers. Services of family medicine physicians were contemplated to be utilized even in the selected secondary care, because we expected if we can train them in the 4 core areas, probably their services could be utilized in the district and subdivisional hospitals, which we call secondary tiers. So it's not that they are only destined for the primary cares. If they're experienced enough, their services could be utilized there also. Then MOU was signed in 2012, curriculum written collaboratively. We framed the curriculum on the basis of our necessity, and that was ratified by the RCGP. Pilot plan accredited February 2013. Entry examination 2013. Course recommended, comments from May 2013. Then RCGP technical visits, there were 3 visits. Annette came, other colleagues also came, Dr. Datta Chandat also came. First took place in July 2013, second was in November 2013, and last was in May 2014, where the exit examination. She came as an observer for that exit examination, and evaluation was done in August and September. The characteristics of this fellowship course was, we had entry examination consisting of 100 MCQs, multiple choice questions, which was set up by our universities, experts of our university, which was ratified by RCGP. Initially 24 trainee seats were declared, 150 total examinees were there in entrance test, and applicants agreed to the government service bond, because government wanted the government doctors, if they have given the approval to conduct this course, they have to sign a bond, so that they have to work in family medicine for 5 years. They cannot leave. Otherwise, you cannot control them. So that was a government strategy. And timetable included rotations in different disciplines I mentioned. Supervised practice in primary health center was included, because there was an observation that there is not much inputs in community observation or community care. So we, this 1 year time is too short a period, so that you cannot put them in all the places. So that's why another objective that we increase the course duration to 2 years. Certificates awarded jointly by RCGP and IHFW. The technical input, curriculum development ratification by RCGP, training development seminar were given initially, then consultation skill training for the trainees, then training site visits and logbook review. We prepared the logbook for the candidates or the students, and that logbook we sent to RCGP and they ratified about the logbook. Then exit examination development, exit examination observation. Then conducting foundation course. Conducting foundation course means we kept 1.5 months time for the basic inputs before we sent them to the hospitals for the family medicine experiences. Then clinical teaching and educational supervision, conducting PHC visits, written and practical examination question writing, exit examination conduction and observership. This is logbook for the family medicine. Of course, this is a logbook for the fellowship course, and we are developing for a different one. We are elaborating it for the diploma course. Now we learned some lessons from these activities, 1 year activities. Based upon the pilot experiences gained, we proposed to launch a 2-year diploma course. So that's the same thing what I was telling about the quarterfinal and semi-final. Then RCGP gained experiences of working jointly with an Indian state institution. I do not know how many Indian government or state-run institutions, government sectors, RCGP is collaborating for running any educational activities. The way outs for combating the challenges of providing optimal medical care in a resource-conscious setting were also identified, and the capacity building of human resources was considered the primary remedial measures. So these are our trainees. They are working in primary health centers. They are actively being involved in all patient care programs. And we thought that the training should be as a patient-centric care. You see, one side, many patients are approaching to the doctors. No, we decided that the training should be in a different mode. So patient-centric means one-to-one. One patient will be attended by a single doctor, so that the primary care could be given. So this is a situation what is presently existing. This is again a photograph taken from gynecology department of one tertiary care, and we want this type of picture after having that. See, the mother with the baby is smiling, you see. Resources and finances, West Bengal funded the local costs, including salaries of the trainees, because we gave them some stipends, and of course the government doctors received their salaries. Clinical training, educational supervision, internal organization and coordination. West Bengal contributed to the expenses of RCGP advisors. RCGP advisors provided their time. RCGP contributed to advisors' expenses and funding of UK program administration and management. Of course, that amount of money, as it was told, it's quite a small amount of money, because they wanted to start it as a noble mission, and we are grateful that they came forward and started or thought working with us jointly. Evaluation was intensive clinical experience, high quality education supervision, collaboration between specialities, and of course, there's small group learning. We are going to select only 24 trainees, And out of 24, 12 from open general case and 12 from the service sponsored candidates. So the small group learning will be expectation to serve the purpose. Benefits of joint working between RCGP and IHFW curriculum, particularly in examination or evaluation. The OSCE type of examination was the first of its kind we adopted while evaluating. Annette was there. She observed throughout the examination pattern. She questioned the examinees. She took part in examination. And OSCE is yet to be implemented in all evaluation practices in India. Effective preparation of trainees work in rural areas, promising basis for supervised family medicine training to post them in secondary tier hospitals in addition. Way forward. We have a MOU signed for 5 years partnership, and that was signed the beginning of this year, middle of this year. Our Chief Minister while visiting UK, it was signed in front of her, and 2 years diploma courses. And the course will include primary care oriented entry examination, foundation course offered as per guidelines, substantial period of supervised training on community care, because that's a very important issue, is to be incorporated in the training component. Project assignment to all training, small project, relevant projects. Joint evaluation by RCGP and WBUHS using the OSCE.
Dr. Ray, you have 3 minutes to go.
I'll finish it in 2 minutes. West Bengal government contemplated to promote the specialty by following modes, as I was telling: declaring family medicine as an independent specialty, creation of specialist posts, absorption of specialists in various policy planning, international collaboration networking, opening master's course in the long run. Said partnership is expected to promote technology transfer. An accreditation of the diploma course by RCGP shall add a brand value to the course. That's our objective of the whole thing. So to summarize in one sentence, the collaboration's excellent spirit of joint learning and enterprise emerges a model for similar family medicine partnerships. So that we look forward to happen, and the acknowledgements from this side and that side. With these few words, I once again convey my grateful appreciation to one RCGP for allowing, Government of West Bengal for promoting, and the experiences what we have gathered. And I again congratulate, or rather I'm grateful to Dr. Raman Kumar and his group for allowing me to share these experiences. And we look forward the inputs and feedbacks from all you experts over here. Our addresses and all availabilities have been given. So please do guide us so that we can go ahead. Thank you so much.